Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Michael Parmley. After completing a 2-year church mission in southern Mexico, Dr. Michael Parmley graduated from Brigham Young University with a BS in computer science. He went on to medical school at St. Louis University in Missouri and then completed his internal medicine residency at the University of Arizona in 1998. He was in private practice for 12 years in the California Central Valley. In 2010, he returned to the San Francisco Bay, where he is originally from, and began practicing medicine in Fremont. Dr. Parmley is board certified in internal medicine and is a fellow of the American College of Physicians.
So basically what this is going to be about, it's going to be about health screening. Screening is kind of an interesting topic, and it's not what you think it is. It doesn't mean we're going to have a film festival or anything like that. What screening actually means is that you've got a bunch of people that don't have any problems at all, are asymptomatic, or at least they don't know about their problems. And you're running tests on the whole group to find the people, that do have the problem. And so that's important to remember. It's different from a diagnostic test. So remember, a screening test is something that you do on a group of people that are asymptomatic. They're okay, or at least they look okay. A diagnostic test, for instance, would be if somebody has diabetes and you have to do, tests every 3 to 6 months and every year to make sure that everything's okay. That's different. You know they have diabetes, and so you're doing a test on them to make sure that their diabetes is being treated correctly and everything like that. So that's different. And so I think like some of the arguments that in the media and other things, they get confused about what they're talking about because they're mixing diagnostic tests and screening tests, which are two separate issues. So what do we screen for, and why do we do it? Well, the idea is, first of all, it should be something really important. It's not, we don't screen for hangnails or your chances of getting hangnails because it's really not a significant issue. It's something that you can treat fairly easily. Something bad like a heart disease or diabetes or some kind of cancer, those are the things you'd want to find. But what would you do? Then the next question is, what would you do if you found them? You wouldn't want to just screen for something if you can't do anything about it. Maybe you would, maybe you wouldn't. That's sort of a different ethical discussion. But you don't want to spend a ton of money to screen everybody in the country for something that's horrible, but you can't do anything about it. So that's another criteria. There's got to be a good test. Some tests are not very good. I guess we could go back to the old days or something, and if a dowsing rod is used to find cancer, it's not a very good test because it's not based on any evidence or anything like that. So it's got to be something that will actually give you a good result. And then the other thing I like to say is the test better not be worse than the disease. So if the only way, for instance, to screen, let's say for brain cancer, was to stick a knife in somebody's brain and take a little piece, I don't think that would be a good idea. So those are kind of the main reasons, what we're screening for or kind of why we screen. So there's really two kinds of screening that we mostly do. There's actually other types of screening. These are the main ones in medicine. So mass screening, where we just kind of screen everybody. You know, we just say, let's just do everybody. And then there's the kind where you take people at risk. So let's say you want to screen smokers, or you want to screen people who grew up in a certain part of the country, or you want to screen somebody who grew up in a country, let's say, where they're at risk for hepatitis or something like that. So those would be examples of sort of tighter screening, but you're still choosing a group of people, remember, that don't have any symptoms. So what are the benefits from it? You can find it. You can find what you're screening for, and sometimes you can cure things before that later would become incurable, like cancer, colon cancer. That's why we screen for colon cancer, because you can cure it. You take out the polyp when you see it, it never turns into colon cancer. And so, but if you wait until it turns into colon cancer, sometimes it's too late. So that's an example. We'll talk about a lot of these later. Sometimes by treating the condition earlier, it makes a difference. Now we'll find that in some of the examples, treating for the condition earlier doesn't make a difference. So the question is, do you want to screen for something that you're going to find earlier, but it's not going to make a difference and not make you live longer? That's another ethical dilemma, because, hey, would you want to know that you're going to die of something in 20 years, even though there's nothing you can do about it? You know, that's one of the concerns and the things that people think about when they decide about these things. And of course, also preventing complications. So if you find somebody with high blood pressure or diabetes early enough and you treat it, then you can prevent a lot of complications later on, a lot of different problems. So, you know, those are the benefits. Now the problem is there are risks and potential harms too. So screening isn't just always safe. You know, sometimes I hear people that come in and say, can I just have a whole body MRI and make sure that everything's okay? You know, first of all, that wouldn't make sure everything's okay, but you could get harms from the test. You'll do a big test, and we find things, we like to call things names that sound fancy, because then we sound smart. So for instance, an example would be an incidentaloma. That's something you find incidentally when you're doing a test to look for one thing and you find something else. And then what do you have to do? You'll get worried about it and you do a bunch of tests, and a lot of times, in fact, most of the time, it turns out to be nothing. So we've done this test and we've gone down this chain of events and we've done all these tests again, and it turns out to be nothing. So there is harm to looking for things. Now there's a lot of false positives, and for that reason, some tests we don't do anymore, or we don't recommend to do anymore. Because, for instance, prostate cancer, or with the PSA, it was found that it was just a lot of false positives. And so lots of men were getting biopsies for nothing. Now, even if they were true positives, most men will die with prostate cancer, but not of prostate cancer. Every man who lives long enough will get prostate cancer. I mean, it may have to be 120 or something, but you know, that's just the way the prostate is. And so the question is, if we're getting so much false positives and also we're finding something that's not even going to hurt you, why are we doing the test? We're just putting people through a lot of misery for no reason. Now, there also are false negatives, and that's kind of annoying too. You know, you come back and the test is negative. Okay, you're fine, see you later. May not be true. You know, if there's a test that you do and it gives you a false sense of security, that may be another problem. Let's say we test you. Let's say we had a false negative on a diabetes test. Let's say you were really diabetic. You know, you'd go out and have pie tonight to celebrate, but that may not be the best thing for you. And of course, you also worry about the cost of the test. I mean, statisticians and things, they worry about the cost as a country and everything. But I've seen people pay a lot of money to do screening tests that based on the evidence are not really valid. You know, they'll go to a place and some guy will say, hey, we'll do the CT scan of your heart, or we'll do this, and there's not really any good evidence behind it. So the question is, why are they spending, you know, $300 a pop or $500 a pop or something to do something that's not going to give you any good information or little good information? And that actually distresses me. There's this one story, my dad, he was a cardiologist, and he told me that once he was touring a facility that shall be unnamed, and they showed him their new CAT scanner to check for calcium in the arteries. And this is when it would just started. And the guy who was showing him around was the marketing director, and he was so excited. He's all, sometimes we'll have such high calcium in their arteries, we'll just rush them right to the cath lab to take care of it. And my dad's thinking, oh, really? And were these people symptomatic at all? Did they have any problems? You know, in other words, it just doesn't sound like a great idea. So, again, as we go through all these things, try not to forget, and I forget too sometimes when we're talking about physicians, we tend to mix up sometimes diagnostic and screening because we're thinking about different things when we talk to each other. But it's normal people or asymptomatic people that we're screening, and they don't have any symptoms. So we're not talking about somebody who comes into the emergency room with abdominal pain. We don't do screening tests then. We do diagnostic tests. So we say, okay, let's figure out what's going on because you're having a symptom. Screening test is a bunch of people go to their doctor and, you know, get it taken care of. I'm also going to add a few things here that aren't necessarily tests, but they're things that you can, you know, also do, certain medications that you can take, or certain things you can do. So, you know, like vaccines and things. So those aren't really screening tests, but I thought it'd be a good idea to throw them in because it's kind of what I would do, for instance, and most physicians do when you come in for your yearly physical or your annual exam. These are the kind of things that we think about. So what I tried to put a list of the adult ones here. So USPSTF means United States Preventative Service Task Force. And they're the people, you know, a bunch of physicians that get together and try and look at all the evidence and figure out what's a good idea to do and what's not a good idea to do. And they'll also say, we have no idea sometimes. They'll say that. They'll say, you know, well, there's no evidence, so it may be a good idea. It may not be a good idea. We can't make any recommendations at this time. So they're the ones that do all the statistics, and so they're the ones that usually get into trouble when they report their findings and they say, well, you know what, you only really need a mammogram every 2 years, and then then people get angry with them. But they're just looking at the data, at all the information that they gather. And so they're just trying to make a recommendation based on what's good for everybody, not necessarily what's just good for one person or whatever. So there's a couple of pages of that. I think you have it in the handouts. You can kind of look and see what they are. So I just kind of wanted to go through all these and just make a few comments. These are very busy slides, but I wanted to make sure you had the information if you couldn't get to it online. Really, the top part of each of these sections tells what the recommendation is. And if you want to, so up in here in this section, and down in this section here, you can see there's kind of a cutoff. It explains it a little bit better. And at the very end, and also down here, there's a link really to where you can get all this information. And it's also on the CDC website, and I have that at the very end too, in case you want to get the whole booklet. It's kind of, but it's, as you can see, sometimes it's a little dry. So, abdominal aortic aneurysm. This is something we do for men who have smoked, who are over 65. it's basically 65 to 75 years old. So and the reason this came up was an aneurysm is something that can kill you. It's the blood vessel, the main blood vessel that goes from the heart down to the bottom of the body. An aneurysm is when it sort of puffs out and eventually pops almost. And the couple of times that I've seen this, the person did not make it. There was even a person that had it in the hospital, rushed them to surgery, and they just don't make it because the blood comes out so fast, there's nothing you can do. So we try and catch it early. So the question is, who is it worth doing it on? So the riskiest population is smokers. And what I thought was kind of funny is they find it as more than 100 cigarettes in a person's lifetime, and that's what, like 5 packs or something? I mean, that's like almost anybody who smoked in men. So it doesn't seem to bother women when they studied this. And in fact, they recommend not to do it because the evidence shows that it doesn't ever find it. Aneurysms are much more common in men anyway. And and basically people who don't smoke, you can see that they don't have as much of a risk. So basically you might find a lot of false positives, or you might find other things. And so you don't really just want to go and screen everybody. So, oh yeah, that's a good point. We should talk about that. There's a section, the grades, it gets a little bit complicated, but basically A means it's a high-risk condition. There's a good test for it. You can treat it easily, all the good things. A B recommendation either means that it's not that important a condition, or it's an important condition. There may or may not be a good treatment for it, but there's a pretty good treatment for it, and there's not a whole lot of potential harm to do something like that. A C means, well, it's getting a little bit worse. We're not quite sure one way or the other. The information is not that great, or it's contradictory. And a D says that, oh, definitely don't do it. It's worse. The risk is greater than the benefit. So like I said, a D would be, cut a hole in somebody's head to see if they have a brain tumor. That would probably be a D. It's not a good idea. Alcohol misuse. This is kind of an interesting one. If you think about it, because it's really actually kind of a simple thing to ask about. There's a lot of different tools you can do. And the problem is, so for instance, adolescents, it's not recommended that they do it. And I'm wondering if it's because they don't tell the truth, or, they're not going to admit that to their parents that they did it, or something like that. But there is evidence that just, a quick questions like, do you ever, worry about your drinking? When you get up, do you have to take an eye opener? Do you ever feel guilty? Does it bother you when people talk about your drinking? Just a few simple questions that you can do, and there's a lot of different screening tools. And it's found that really helps, because sometimes people may want to do it, or they just don't think about it, or their friends and family don't talk about it. So I've seen that help a little bit. Well, maybe once or twice, but it does help. I wish it would help more often, but. Okay, aspirin. This is the question I always get. Should I take an aspirin, doc? Yes or no? That's the question. So basically, if you look at it, women are about 10 years behind risk with cardiovascular disease than men are.